Disease Control Delhi. My God, her CV is very long. Ma'am, your CV is very long. I will cut it short. Else will we just be talking about you in the whole webinar. So
No, that much of introduction is enough. You please go ahead. हो गया.
so it's a very long CV. So in fact, she has a best paper in virology, Lewis Pasteur Oration Award in 2014, and she has scientific paper published in more than 60 in national and international journals. And she's co-authored the national guidelines for anthrax, dengue, the epidemic endemic in Delhi. Japanese encephalitis, again epidemic endemic in Delhi. Leptospirosis, almost everything which is there in Delhi, rabies. So welcome, ma'am. Sorry, welcome, ma'am. So Suresh sir, over to you. And Mala ma'am, would you like to say something before we start?
Uh,
You have to unmute, ma'am. Yes, ma'am. You're right.
so thank you for the opportunity, and I'm really it's immense pleasure to be here because this subject is very close to my heart, and I've been working on this for last 25-26 years and closely with Dr. Gupta as well. So I'm just waiting to hear from him. I'm sure new perspective is going to come in, which is this is rabies is a major public health problem, 10% mortality, and but nearly 10% preventive. We can totally prevent it, and this is one of the best ways, and we have one of the best speakers to speak on it. So, Dr. Suresh Gupta, we are ready to hear you.
Over to sir.
Thank you, Dr. Mala and Dr. Mukesh. And Dr. Mala was heading the genetic department in NCDC, and now she has moved to RML. And in the past, we have done lots of programs on rabies in association with Dr. Mala. And her presence is always very, very useful for all the difficult questions, actually, which we cannot tackle directly. So she is there to answer all those special situations also. So I'll go on to directly my presentation. Right. So what is the burden of rabies in India? Right. First of all, I will mainly focusing on post-exposure and pre-exposure prophylaxis. I'm not talking about the disease manifestation much or prevention of rabies in animal, and mainly it will be human rabies which I'll be dealing with. So in India, it is estimated that 20,000 human deaths are caused by this disease, and every year almost you can say 2 crore of animal bite occurs, and 96% of the human deaths caused by rabies, right, are dog-mediated rabies. And you can see these pictures, and these are red one are the one which are the very, very high on, right? And this second picture shows the state-wise animal bite prevalence, right? And these Gujarat, Maharashtra, and these are very high animal bite populations. So regarding mode of transmission, commonest one is I think more than 95%, 99% are caused by dog, and some are caused by cats. Other occasionally rabies transmitting animals are monkey, mongoose, shrew, cows, buffalo, foxes, wolves, jackal, sheep, goat, and sometimes bears, pigs, donkey, horses, camel. Camel are particularly important in Rajasthan. I think few cases have been reported from Rajasthan. And bats, rodents are particularly not reported from India. Birds and squirrel are also not important transmitter of rabies in India. Remember that all exposure with wild animals are considered category 3 exposure. So bite by bats and rodents do not only necessitate rabies vaccination in India. However, bite by bats or rodents in unusual circumstances may be considered for vaccination in consultation with an expert like Dr. Mala. Regarding pathogenesis, the incubation period in most of the cases is 2 to 3 months, while in 2 to 3% cases, sometime incubation can period be up to 1 year. And after 1 year, it's very, very rare that rabies will occur after the bite, though there are few exceptional cases, even up to 8 years. So because of wide range of incubation period, post-exposure prophylaxis should be given as soon as possible. However, it should not be denied. It should not be it should not be denied even if the person is reporting late. As you know, the pathogenesis that after animal bite, right, rabies inoculated over there, then there is a replication of the virus in the muscle and from the skeletal muscle, and then it travels along the dorsal root ganglion and reaches over here where, and then replication occurs in motor neuron of the spinal cord and local dorsal root ganglion, and rapid ascent to the brain happens. Centrifugal spread along the nerves to salivary gland, skin, cornea, and organ, and ultimately it causes encephalitis, infection of the brain and neuron with neuronal dysfunction. The rabies presentation, it can be a classical presentation or it can be paralytic rabies actually. After exposure, generally within 2 to 3 months, first symptom which start is fever, pruritus, and paresthesia at the site of bite. And then after this, all the typical symptom of rabies starts in the form of hypersalivation, piloerection, dilatation of the pupil, and hydrophobia, aerophobia, dysphagia, respiratory spasm, hyperventilation, and hematemesis. And aerophobia is as important as acrophobia. Aerophobia also as important as hydrophobia. And many times what happened during our residency days, and children were brought to emergency, and when the child was being brought to emergency in three-wheeler, because of lots of air movement, right? Child used to get frightened too much because of laryngoscope. Sometimes it can be paralytic rabies, which is not a classical presentation. Again, these are the prodrome symptoms, and here is more like a paralysis along with other symptoms, and then drowsiness. These are the differential diagnosis, or you can say any child who is presenting with symptoms suggestive of Guillain-Barré syndrome, viral encephalitis, poliomyelitis, transmyelitis, cerebrovascular accident, psychosis, epilepsy, atropine poisoning. Right? One of the differential diagnosis should be rabies in these cases also. So what are the steps of management of animal bite cases? 3 important steps, right, in which the whole treatment can be summarized is management of the animal bite wound, including exposure assessment and wound washing. Second step is active immunization with anti-rabies vaccine. And third, passive immunization with rabies immunoglobulin if indicated. So how do we assess the exposure? Exposure is categorized in 3 categories, right? Category 1, category 2, category 3. Category 1 is basically just touching or feeding an animal and licks on intact skin or contact on intact skin with secretions or secretions of rabies animal or human skin. And here you can say no exposure or class 1 exposure, right? And only thing which is needed is wash the exposed area with soap and water for 15 minutes and then apply antiseptic. And there is no need of any rabies, immunoglobulin or vaccination. Category 3 is nibbling of uncovered skin or minor scratches or abrasions, but without blood. Without blood. Even a small amount of blood moves this category to the category 3, right? Here we just do vaccination along with the wound management. Category 3 is basically transdermal bite, any licks on the broken skin, contamination on the mucous membrane and saliva, right, from the licks. And let me tell you, most of the bites which are brought to emergency room are generally category 3. Category 1 and category 2, most of the people think there is no exposure at all, and many times they don't come to us. Right? So even a small amount of blood coming from the wound makes it category 3 bite, and it doesn't matter where the bite is, whether it's on the hand, on the legs, on the palm, on the face, on the trunk, right? Any bite which is transdermal, right, should be taken as category 3 bite. And here, in addition to wound management and immunoglobulin and vaccine, all 3 components are needed. Let us talk about wound management first of all. So in wound management, there are 3 things we do to inactivate the virus physically, chemically, and biologically. Physically, we wash each wound with running water up to 15 minutes. It causes mechanical removal of the virus from the wound. Chemically, after cleaning the wound, you clean the wound with soap and water, and this soap basically causes chemical inactivation of the virus, and you also apply antiseptic. Soap causes dissolution of the that virus lining, which is made of lipoprotein. Biologically, you infiltrate rabies immunoglobulin at the site of wound, right? And it locally inactivate the virus over there. So this is the basis of doing washing with the water, chemically, particularly with soap, and applying antiseptic, and biologically by injecting rabies immunoglobulin. So washing of each wound is desirable up to 15 minutes, and it should be carried out as soon as possible. Even if the patient is coming late, after 10 hours, 12 hours, 20 hours, even then the wound washing should be done. You gently clean the wound with detergent or any soap which is available. Soap is very, very important because it chemically neutralizes the virus. Apply available versatile topical preparation, antiseptic agent, and iodine containing agents are particularly useful, right? If unavailable, alcohol can also be used. Remember, do not apply any irritant to the wound like lime or chili powder or turmeric powder or tobacco, coffee powder, etc. because these will propel the virus deeper to cause nerve infection and ultimately leading to rabies and encephalitis and mortality. Also avoid bandaging or covering the wound whenever it's practical and feasible, and open dressing is always recommended. And this wound should never be cauterized because it will further spread the virus along the nerves. avoid primary suturing of the wound. If needed, a loose suture can be applied, and this should be done only after infiltrating rabies immunoglobulin. In long run, then later on, a second suturing can be done if needed. And that is done only after 2 weeks when the seroconversion has occurred and the patient is protected against the rabies. Administration of rabies vaccination in post-exposure prophylaxis. So there are 5 or 6 kind of rabies vaccine which are available. All the cell cultured vaccine, all of them are equally effective, and when they administered by intramuscular regime or intradermal regime, rabies vaccine is produced as one single IM dose, right? And it has a patency of 2.5 international unit per IM dose, and it is used for pre-exposure as well as post-exposure. Same potency is used. Every batch of cell culture vaccine must have a minimum potency of 2.5 international unit as per WHO recommendation, irrespective of whether the vaccine is administered intramuscular or intradermal. So potency remains same, and it is 2.5 international unit irrespective of the route of administration. Site of vaccination remains same whether you are using intradermal route or intramuscular route. It is either given over the deltoid region, and it can be used in adult and children. If in small children you cannot use the deltoid region, in those cases you can use anterolateral thigh, but never use gluteal region because there are lots of fat over there, and lymphatics are not good over there. So vaccine uptake is relatively poor in this area. And rabies exposure is such a thing where we want a rapid onset of seroconversion. So let us talk about intradermal rabies vaccination. So how does this intradermal rabies vaccination works? So anti-rabies vaccination is picked up by the anti-presenting cell. Over here you can say dendritic cell, also this is called, or Langerhans cells, which are present in the skin and presented to the local regional lymph node. From there it is taken to the local regional lymph node, and in turn it elicits both B cell mediated and T cell mediated. And remember, intradermal rabies vaccination is as effective as intramuscular rabies vaccination, maybe a little better than intramuscular. The route which is approved for intradermal vaccination by NCDC is this updated Red Cross Thai resin, which is 22202. And the meaning of this 22202 is that on 0 day, you give 2 doses of intradermal vaccine, right? And again, second 2 stands for this 3rd day. And then on 7th day, again you give 2 intradermal doses. 0 stand basically that on 14th you are not giving any vaccine over here. And then on 28th, again we give 2 doses intradermal vaccine. Site again remains either over deltoid region or anterolateral thigh. It's not given either in arm or abdomen. The way to introduce intradermal, I think most of the pediatricians very well aware, right? So in intradermal, the bleb should be formed of around 2 to 3 millimeter. Only then you can say that it has really gone intradermal. If the needle is incorrectly placed inside the dermis, resistance is felt while injecting the vaccine. So it's a intradermal, not below the dermis. If the vaccine is injected too deeply into the skin, right, subcutaneous, a PD orange kind of appearance will not be seen like this. So this is important. Then the needle should be withdrawn and reinserted at the adjacent site and intradermal vaccine given once more. If your inoculation is not proper, you have gone very deep and you have not seen the blood, so in that case, you repeat the vaccination and nearby site with the same volume of 0.1 ml. Once the vial is opened, it should be stored at 2 degrees centigrade, maximum 8 degrees centigrade, but it cannot be stored more than 6 hours. After that, it has to be discarded. But instead of discarding, this vaccine can be used for pre-exposure prophylaxis for healthcare providers. The purpose of giving intradermal vaccine is to save the volume of the vaccine. So this is important in rabies clinic. But for individual practice, those who are doing the individual clinic practice, in those cases, intradermal vaccine should not be used because anyway, whatever the remaining amount is there, it cannot be reused on the next visit. So in individual practice, always give intramuscular, but in rabies clinic, to save the cost, it is given intradermal. In intradermal, the patient needs 8 injections, 2, 2, 2, 0, and 2. But in intramuscular, only 5 injections are given. Coming to intramuscular, this is also called SN regime 1, 1, 1, 1, 1, and one dose is given on day 0, day 3, day 7, day 14, and day 28. Right? Day 0 is basically the day when you're starting the vaccine. Day 0 is not the day of bite. Right? If the patient is presenting on the same day and you're giving vaccine, then become day 0. And suppose the patient is coming on 3rd day, and then that become the day 0. So IM dose given and on 0, 3, 7, 14, 28. Again, it is either given in deltoid or anterolateral side. It should never be given in gluteal region. And of course, a wound washing is done. Switching the route of administration for intramuscular to intradermal or vice versa, or switch over from one type of modern rabies vaccine to other is not recommended and it should be avoided. Irrespective of the route of administration, completing the course of post-exposure prophylaxis is essential to prevent the disease. And the evidence suggests incomplete post-exposure prophylaxis may lead to progression to the rabies disease. Let us talk about passive immunization, and that is rabies immunoglobulin. Remember that even the best modern vaccine take at least 10 to 14 days, or you can say 3 injection minimum on day 0, 3, 7 to elicit protective antibody titer, which is 0.5 international unit per ml of serum. And to cover up this period of 10 to 14 days, when the patient is unprotected, but rabies can travel to the brain and cause rabies encephalitis. To cover this period, rabies immunoglobulin is given this incubation period, to cover this short incubation period, particularly for severe wound or class 3 bites. So this rabies immunoglobulin is given at the site of bite, and this is a virus, and after giving immunoglobulin, it's immunologically inactivate the virus. This virus is not able to enter the nerves. What are the indications for rabies immunoglobulin? It is given to all patients who have category 3 exposure. It is given to all wild animal bites, even if they are class 2, apparently class 2, they are always considered class 3 bite. Right? And immunocompromised individual like HIV or AIDS, or patient is on immunosuppressive therapy or having some congenital agammaglobulinemia. In these cases, we give immunoglobulin even in category 2. So we can say that in an immunocompetent person, it is given for category 3. And if it is immunocompromised, it is given for category 2 and 3. And all kind of wild animal exposure are considered category 3. Even in those cases, it should be given. Remember that RIG alone is not sufficient, and vaccine also has to be used along with this. And suppose the patient is coming late and bite has got infected. So after cleaning the wound, right, the RIG should be injected in the wound itself, and presence of infection in the wound is not a contraindication for administering the rabies immunoglobulin. So, but RIG is not indicated, right, in those patients who have previously received the vaccination, right? Pre-exposure or post-exposure prophylaxis in the past. And it is also never given beyond 7th day after the first dose of rabies vaccination, regardless of whether the dose was received on day 3, day 7, because an active antibody response to this rabies vaccine has already started, and giving the vaccine, giving this rabies immunoglobulin will be wastage of immunoglobulin, and moreover, it may impair the seroconversion or antibody response on the part of the parent. This point I would like to highlight little more, that when we say day 7, day 7 means after starting the vaccination. Day 7 after starting the vaccine, not day 7 after the wound. Suppose patient has bite 3 days back, and today you are giving the vaccine. So today will be count day 0. So up to next 7 days, we can give the immunoglobulin. Not first 7 days of the bite. First 7 days within the first dose of vaccine, we can give the immunoglobulin, irrespective of when the bite occurs. So there are two kinds of immunoglobulin, all of you know, right? Equine rabies immunoglobulin, human rabies immunoglobulin. The preparation which are available with equine are 300 internal unit per ml, and with human it is 150. Dose for human is 20, and for equine it is double. And the maximum dose for human is 1500 units, and for equine it is 3,000 international. So even if by weight the dosage calculation comes more than this, that is the upper limit. For equine it is 3,000, for human it is 15. Mode of administration. Remember, the full dose should be given. RIG should be brought to room temperature before administering to the patient. Otherwise, it can be very, very painful because the vaccine and immunoglobulin are stored at very low temperature. RIG is more effective if it is infiltrated immediately and the earliest. However, RIG can be administered any time if the person has not received any vaccine, but it is always beneficial to administer RIG at the earliest. It is important to infiltrate all the wounds with RIG, neutralize the virus locally. Suppose there are multiple wounds and your vaccine is, your immunoglobulin not sufficient to infiltrate all the wounds. In those cases, you can dilute the RIG with normal saline and administer in all the wounds. And as I told you, that in case of multiple wounds, RIG should not exceed the maximum permissible limit, because if you give the dose more than this, then it may interfere with the seroconversion or vaccine effect. To cover all the wound, RIG can be diluted maximum with normal saline. Initially, the focus on this patient should be to proper wound toilet before administering any RIG. So wound toilet is very, very important, very, very important. So wound washing, vaccine, immunoglobulin. Each one has got equal role to play in rabies prevention. No wound should be missed with RIG administration, even if it looks very small and trivial. The entire immunoglobulin, or as much as anatomically possible, right, should be infiltrated carefully in the edges and the base of the wound and as close as possible to the wound or exposure site, right, till traces of RIG oozes out. It is preferable to use separate needles for infiltrating different wounds. Multiple needle injection into wound should be avoided as far as possible. So you enter the wound from one side and inject the whole margin rather than giving multiple injection in that particular wound. RI should never be administered in the same syringe or at the same anatomical site where the vaccine was administered. For mucosal exposure with no wound, rinsing with RIG can be considered. So there is a exposure of the mouth mucosa. In that case, RIG can be used to wash that instead of. Intramuscular administration RIG is of very little value, and evidence suggests that injecting the remaining RIG volume intramuscularly at a distance from the wound provides little or no additional protection against rabies as compared to infiltrating the wound. So whatever amount we have to give, we should give at local site or around the wound. Remember that there is a high likelihood that there is additional small wound if a child doesn't report all wound. Injection of the remaining RIG intramuscular or as close as possible to the presumed site or to the degree that is anatomically feasible should be given. In case of suspected exposure to RAB via aerosol, an intramuscular injection of RIG is still recommended. As for all immunization, animal bite victim should be kept under observation for at least 15 to 20 minutes after administering the immunoglobulin. And we know that tetanus toxide or TDP should be administered if not already received. Course of antibiotic and analgesic as indicated. I will show just this video or this how this RIG is administered. You can see that this child has multiple wounds. So it has been taken in a syringe. You can see this person is going on the one edge of the wound, right? And after withdrawing, checking that is not in the vein, it is slowly being administered, right? And till little oozing. And then you enter on the other side edge and slowly inject while you withdrawing it, little slowly. You can see this is quite a big wound and there are multiple edges. So in that case, we administer all around. So this immunoglobulin is a quite a thick solution. So small gauge needle may not work. We may have to take a thick needle. The third way is being injected. So to summarize this whole thing, category 1 exposure is only touching or feeding animal or licks on intact skin. In these cases, vaccine and RIG not indicated. We just wash that area for 15 minutes. Category 2, you can say mild exposure, minor exposure. We just a nibbling of the uncovered skin in which no blood has come out. Minor scratches or abrasion without bleeding. In addition to washing the wound, giving rabies vaccine, complete course. In category 3, with a transdermal bite or contamination of the mucous membrane with saliva or lick on broken skin. All these 3 things are we did. Wound management, rabies vaccine, RIG infiltration. Regarding RIG infiltration, particularly when you're using rabies, equine rabies immunoglobulin, now most of the people advise they no need of testing, doing a intradermal skin test before infiltrating. So what about those patients who were previously exposed and received the vaccination in the past? For exposed or re-exposed patient who can document previous complete pre-exposure or post-exposure prophylaxis, following things are done. Of course, wound washing, right? And in these cases, we can give one site intradermal vaccine on day 0 or 3, or in a clinic setting, we can give intramuscular on day 0 and day 3. Only 2 doses are needed on day 0 and day 3, and there is no need of rabies immunoglobulin administration, even if it is category 3 bite or multiple bites or big wounds are there. If person is not sure about the previous vaccination, whether that was complete or not. In these cases, the patient should receive complete post-exposure prophylaxis, including rabies immunotherapy. Only after completion of complete course of the post-exposure prophylaxis, right? Pre-exposure occur within 3 months. Right? Nothing to be done except for wound washing. But if a bite occur after 3 months, the vaccine is to be given as per schedule on day 0 and day 3. This particularly can be an issue in small children who are having pet dog at home, and they are very in habit of playing with that pet dog. And if the bite occurs 3-4 times in a year, then they may need multiple doses of rabies immunoglobulin. And we will discuss this point particularly with Dr. Mala. So if unvaccinated, in this case, rabies plus immunoglobulin, both the things. If vaccinated only in the past, then only vaccine, no RIG. Now coming to immunocompromised patients. The things which you have discussed till now is for those who are immunocompetent. But if the patient is immunocompromised or patient in whom the presence of immunological memory is no longer assured, the following protocols is followed. Good wound management, including meticulous, very thorough wound cleaning and antiseptic, accompanied by local infiltration of immunoglobulin for category 2 and 3, both are things. Even if these patients have received vaccination in the past, right, they will need full course of vaccine along with immunoglobulin. If possible, we can test these patients after 2 weeks and estimate their antibody level, whether they have really reached the protective concentration or not. So animal consideration regarding post-exposure prophylaxis. Regarding observation of the biting animal. Remember that observation is meant only for dog and cat, and dog and cat also only if it is a pet dog or pet cat. Right? There is no way we can observe a random cat or stray dog. Right? All the dogs look same. Somebody may say, this is a black dog, same has bitten me. But all the dogs may look same on the street. So this is only for a dog which is bad. If the dog remains okay for 10 days, in these cases, the post-exposure prophylaxis can be converted to pre-exposure prophylaxis. It means that you give the dose 0, 3, 7, right? You can miss dose 14, right? And then you can give just one dose on day 28 to become pre-exposure prophylaxis. But this is not applicable for intradermal route. Right? So this exposure of biting animal, cat or dog in intradermal route, this is the course is to be completed irrespective of the status of the animal. Vaccination status of the animal. Although unvaccinated animals are more likely to transmit rabies, but vaccinated animals can also transmit virus in case of ineffective vaccination for any reason, right? They have not received proper dose or they received ineffective vaccination or the vaccine was not properly stored. Hence, irrespective vaccination status of the biting animal, post-exposure PEP should be given, must be given. Regarding provoked or unprovoked bite, it doesn't matter. Right? We can never say that provoked animal bite cannot be a rabid animal. So they are treated in the same manner. Coming to some of the deviation in the post-exposure prophylaxis schedule. First 3 doses, days 0, 3, 7, should be completed maximum within 7 to 10 days to achieve effective immunity against the rabies virus within 10 to 14 days. These 3 doses are the most important. 1 or 2 days deviation does not necessitate restarting of the vaccination schedule. Remaining doses should be given as per original schedule starting from day 0 dose. For most minor delay or interruption, vaccination schedule can be shifted and resumed as the patient was on the schedule. However, in circumstances where the patient fails to visit on the scheduled dates of first 3 doses, days 0, 3, and 7, if they are not completed in first 10 days, so in these cases, additional dose should be considered to achieve effective immunity. There is no absolute contraindication for post-exposure prophylaxis. It can be safely given to newborns, pregnant women, and of course, immunocompromised individuals. So in general, anti-rabies vaccines are safe and well tolerated. And suppose there is some pain or inflammation, we can use anti-inflammatory or antipyretic. If there is a history of hypersensitivity, we can use antihistaminic. And even in case of severe hypersensitivity reaction, we must take the opinion of a allergy specialist, and a vaccine should be administered under his supervision. Post-exposure prophylaxis failure is very, very rare if it is followed properly, including all the 3 components. Right? Failure generally occurs when the patient is reporting late, or wound washing is not done properly, or there are some wounds which were not washed or remained unnoticed. Application of irritant on the wound facilitate transmission of the virus. Right? Suturing of the wound also transmits virus faster if it is done without administering the rabies immunoglobulin. And of course, we don't give RIG to category 3 bite. Post-exposure prophylaxis failure can happen. Other reasons for failure are incomplete infiltration of all the wound, and full dose of RIG instead of administering in the wound is given intramuscularly, or if vaccine course is not completed, or vaccine is given in gluteal region. If the vaccine by mistake is given in gluteal region, another dose should be given in that place, in the proper site. Sometime inoculation of the rabies virus directly into the nerve or extensive deep bite, post-exposure prophylaxis may fail. Immunocompromised individual. So, what are the newer advances in post-exposure prophylaxis? And we know there is a monoclonal antibodies available nowadays as a cocktail containing two antibodies. It is from the Serum Institute of India, and it can be used in place of rabies immunoglobulin. So, one of this vaccine has been recently licensed by the drug controller government of India, and WHO recommend that a registry should be maintained to monitor the clinical use and outcome of this monoclonal antibody products for rabies prophylaxis. Expert groups recommend that role of monoclonal antibodies in case of category 3 bite as replacement of RIG should be properly studied, and its effectiveness and safety should be researched. The dose of this rabies monoclonal antibody, which is available from Serum Institute of India, is 3.3 units per kg. So in addition to those three limbs, it's equally important to educate the patient. So do not rub the injection site. Do not apply anything to the injection site. Avoid excessive alcohol and restrict smoking. Strenuous physical or mental work should be avoided. No specific dietary restriction. They can take bath regularly. Of course, discourage use of chili paste or any other irritant or any other home remedies. Domiciliary practice should be discouraged. Take prescribed TT, anti-inflammatory or antibiotic. Do not apply any other cream to the wound, any dressing or bandage. Continue medication if undergoing for other diseases. Emphasize the life-saving value of anti-rabies treatment and need for compliance to complete the course of vaccine. Inform about scheduled dates and highlight the importance of timely administration. And whenever relevant and feasible, observe the dog and cat daily for 10 days, and on suspicion get a veterinary examination done. Special situation. Person consuming raw milk of a rabid animal. One should boil the milk before consumption. I think most of Indians follow this only because it kills the rabies virus. And there are no documented cases of rabies transmission by drinking milk of rabid animal. So consumption of milk produced by rabid animal does not require any kind of prophylaxis. Rabies can be transmitted by ingestion of experimentally infected animal. However, no human case resulting from consumption of raw meat from a rabid animal has been documented. So it is not advisable to consume the meat from a rabid animal, particularly if it is raw. If exposure occurred, in these cases, post-exposure prophylaxis should be initiated. Pregnancy and lactation contraindication, dosage schedule remains. In HIV and AIDS, we have got very low CD4 count, right? One should, sorry, right? Where the CD4 count is very low. In these cases, wound treatment, RIG, and 5 doses of vaccine only intramuscular. In these cases, we should not use intradermal route. And rabies antibody assessment should be done after 2 to 4 weeks, if possible. Even if patient is receiving chloroquine therapy, right? Even in these cases, intradermal route should not be used. Only IM route is to be used. If there is a history of previous severe adverse reaction, you can consider to change the type of vaccine. You can use different brand and try that. Switching over from one brand or type to another vaccine, it should be avoided as far as possible. In case vaccine is not available or unavoidable, in those cases, it can be used to complete the course of PAP. Shifting from one route to another, from IM to ID or IN to IM, is not recommended because there is no sufficient evidence regarding seroconversion in these cases. Irregular incomplete vaccination, as a general thumb, 3 doses of vaccine must be administered within 10 days, 4th and 5th dose, right, by IMID by day 28, and there is no need to restart the vaccine if there is a delay of few days. Suppose a patient comes very late after animal bite. In these cases, the post-exposure prophylaxis, even if the wound has healed, suppose the patient come after 2 weeks, even if the wound has healed, right, RIG should be administered at the site of bite, even if the wound has healed, even if there is no bite mark, and complete course of vaccine is given. Regarding other vaccines along with rabies, yes, it can be given. Post-exposure prophylaxis is indicated for high-risk group, just like laboratory staffs or veterinarians, animal handler, dog catcher, wildlife warden, quarantine, travelers from rabies area to endemic areas. However, Indian Academy of Pediatrics has recommended pre-exposure prophylaxis for children, and this may be offered on voluntary basis because the children are very fond of playing with the dogs, even street dog. So anytime exposure can occur. Schedule for pre-exposure is on day 0, 7, and 3rd on day 21 or 28. Right? It can be done either IM route or intradermal route. Suppose the patient has received 0, 3, and 7, even though he has received 3 doses, it will not be considered a complete post-exposure prophylaxis or pre-exposure prophylaxis unless he has received 1 more dose on 21 and 20 or 28. I think this point we discussed that high-risk group should have their neutralizing antibody titer done every 6 months who are working in these labs. So I will complete this presentation here only, and we can take up the discussion and questions. Thank you.
Thank you so much, Dr. Suresh, for a wonderful, wonderful presentation. And you've beautifully highlighted the national guidelines on animal bite management. And things that have come up are that animal bite management is an urgency, if not emergency. Like one has to give animal bite management as soon as possible. And the first step is washing the wound with soap and water. If soap is not available, do it with water alone. And this is very, very important because that's the first step in decreasing the viral load. And most of the times one forgets that, followed by the other methods that you said is applying antiseptics and infiltrating it with immunoglobulin. So so it is mechanically removing the virus, chemically inactivating the virus, and biologically neutralizing the virus by this thing. We've also spoken about three-pronged approach of animal bite management, that of wound management, that of giving active immunization by anti-rabies vaccines, and passive immunization to cover that period till the active immunity takes place. So that is again very important. Another important point is that we always get confused about the observation period as to how long the animals can be observed. And you said that the observation period is valid only for dogs and cats and no other animal. So exposure can happen to the list of animals he showed to any of the animals, but in the observation period is valid only for dogs and cats for the simple reason that incubation period is defined for them. For others, it is rabies has a variable incubation period, and for this is the reason the virus may lie dormant in the wound, and that is why benefit of doubt is given to the patient. Even if the patient reports late, the person should be given complete post-exposure prophylaxis. So these are, carry home messages which is given. And I can see some questions in the chat box. And Dr. Gupta, please, you have covered most of them, but you can still again answer them. First question is like same vaccine can be given either IM or ID?
Yes. I think we discussed this point.
We have discussed this point, yes. So it's the same vaccine and the same IM vial dose becomes the multi-dose ID vial. Only thing is the potency remains the same, more than 2.5 international units. And only thing you have to be careful is that when you're using a same vial for multi-dose vial, you have to be very careful and store the vial properly. So second question is, if patient comes with incomplete PP, do we start the whole regimen from beginning? You've answered that you have to cover first 3 injections in 10 days. Yes,
we
absolutely.
can just highlight again, first 3 doses within 10 days, important, very important.
Right? Absolutely.
Now, if those 3 are given, if 4th or 5th dose is delayed, right, that is okay. Then it can be given as such. But if first 3 doses are not given properly, then it has to be restarted.
Yes. Next question is RIG better than monoclonal antibodies?
Regarding monoclonal body RIG, though it is recommended as a replacement for RIG, but still there are not enough study to compare these two, whether monoclonal antibodies as effective as RIG. And Dr. Mala, I think probably can highlight if there any research on this or not.
Yes, sir. Thank you for that. And a very good question. So WHO initially recommended cocktail of monoclonal antibodies. Definitely, we can totally understand that when we give anti-rabies immunoglobulins, those are raised in horses or in humans, they are complete entity and they represent all the antigenic site of the virus, whereas monoclonal antibodies are 1 or 2 clones of the antigenic structure. So we have to be very sure as to what clones, and that is why Dr. Gupta said that not enough studies are there, but this was in 2019 and 20. After that, number of studies have come up, and these monoclonal antibodies have been found to be effective. And probably next, DCGI, as Dr. Sabha said, has already approved them, and they are indigenously produced, so cost will come down. And so I think there is some enough literature now. So in next national guidelines, maybe they may be included in the national guidelines along with RIG. I hope that answers the question. So the next question is, what is the bite? What if the bite is by the domestic puppies, less than 3 to 4 months old?
It remains same, it doesn't matter.
Yeah. So all dog bites, even puppies can transmit the disease. So they should be treated as if like any other dog bite. So I think I can see only these questions. If there are any other questions, then you can type in chat box. And if there are any other comments or something from anyone else from the organizing team, I think we can open it for discussion with the organizing team. But it was a very good talk covering all the aspects. And another question that often is asked is pre-exposure prophylaxis. Why can't we give it to, now it is given for high risk. Who's at high risk? Dr. has given a big list, but morning walkers, children playing on street, with domestic dog population being so high, everybody is at high risk. So there is, a lot of thought process going on that every children should be included in universal UIP and should be given, but still, because we have to see at so many other aspects, that at least post exposure prophylaxis everybody should get, and we should not run short of vaccine. So we have to make certain guidelines, though IAP has already recommended it, but it is good to have pre-exposure prophylaxis, especially people who have pet animals. And please don't underestimate pet dog bites because sometimes pet dogs may, the owners may not be taking care of pet dogs, and pet dogs may be going out alone. But if it is your own pet dog, vaccinated, you are getting him vaccinated annually, and you have also taken pre-exposure prophylaxis, then every pet dog bite from your own pet dog may not be treated, but wash the wound with soap and water and continue taking annual boosters. That is important, right? Because
somebody asked, drinking cow or cow's urine, can that cause rabies if it is rabid cow? I think this point we have discussed that at least drinking milk doesn't cause rabies.
थोड़ा डाइट थोड़ा वो पेट में वट सा उठ रहा है ना, ठीक हो जाएगा.
There is one more question, human to human transmission.
Yeah, so cow's milk usually will not, because the milk becomes acidic, and the rabies virus is very labile virus. It is not a hardy virus. So in acidic environment, that's what they say, why consumption of rabid cow milk, raw milk, it doesn't need prophylaxis, is because the quantity of virus will be very low. Second, the acidity and the salivary enzymes, they inactivate the virus. Similarly, in cow urine, the virus may not survive, right? So that we don't recommend, if person has consumed urine of the rabid cow, to be having post-exposure this thing, because acidic environment, it will not survive. But having said that, whenever in doubt, I think rabies is one disease which is 10% fatal, and it is 100% preventable also. So whenever there is a doubt, if you cannot contact an expert, if you have to make an error, make it on the right side. So over treating may not be a problem, but under treating may be. So in any situation, if you are in a doubt, please contact somebody who has knowledge of the subject. And if it is not possible, then err on the right side. That's very, very important when it comes to animal bite management and rabies.
Yeah, can I ask a question?
Yes, please.
Yeah. So in Lakshadweep, my daughter had been there in one of the islands. She got bitten by the dog, and she went to the PHC, and she was told no rabies has ever occurred there. So they don't give anti-rabies vaccine. Mm-hmm. So now she's back, and I was just wondering, do I need to vaccinate her?
Well, she's absolutely right, ma'am. Two islands, group of islands, Andaman, Nicobar and Lakshadweep, are, they are free of rabies, historically free of rabies. And now we have collected some samples and done a seroepidemiological study. Also, we have not found any rabies there, because the virus has not reached there, because they are waterlogged islands. If the rabies virus reaches there, that is why they're very particular that when animals are brought in the island, they're all screened and quarantined before they are let in the islands. So Lakshadweep and Andaman, they do not have any policy of giving anti-rabies vaccines, which is correct. But let's hope that the virus doesn't. But how long back was the dog bite to her?
4 days back.
4 days back. No, if she's had a dog bite there and she's come here, and there are very few dogs in Lakshadweep, I think 2 or 3 dogs only. Now, if they've increased, I
On
don't
this
know.
island, no, she was surrounded by 5 dogs actually, and they are all they are all scratches, but definitely they look red after. So, though no active bleeding was seen, but even she wasn't aware. When she took off her clothes in the room, she realized she has had 5, 6 scratches, big scratches.
So she can, I mean,
I think, yeah, it should be, yeah.
Yeah, there is no need for this particular exposure, but pre-exposure prophylaxis this is the opportunity to take post-exposure prophylaxis and protect her.
Yeah.
Look,
Thank you.
can I ask a question?
Yes, please.
Yeah. Dr. Suresh, one that is there after pre-exposure prophylaxis has been done, so then the post-exposure always throughout life remains 2 doses, 0 and 3 months, or you need to, after certain years, you still come back to the full 4 or 5 doses?
Dr. Pankaj, it always remains 2 doses unless there is some immunocompromising condition has occurred to the patient, right? Unless the patient is on some immunosuppressive drugs. Otherwise, it always means 2 doses, 0 and 3,
Throughout
irrespective of
life,
the time gap.
and no intra-lesional injection.
No RIG.
No RIG forever.
Yeah.
Right.
That is the purpose of giving rabies pre-exposure prophylaxis.
And other is that apart from this Lakshadweep and Andaman, which we just came to know, there are other countries also which are free of rabies, and if there's a dog bite there, then they don't recommend the vaccine.
Singapore, Switzerland.
Yeah.
Switzerland.
Yeah. So some European countries are free of rabies, like Dr. has mentioned. Now they are focusing on wildlife rabies. So only few countries, I think Australia is one of them. They do not give post-exposure prophylaxis unless it is lab proven that the animal is rabid. So they first test the animal and then decide to give post-exposure prophylaxis. But we cannot do it in our country because, of course, disease is endemic here. So, but I think 4 or 5 European countries are now free of free of domestic rabies. But wildlife rabies, they are trying to do bait in wildlife and trying to, immunize the wild animals as well. But it is very difficult to do that because it's a zoonotic disease. It will find its reservoir somewhere or the other.
And another practical question which I had a child who got bitten by a stray dog on thumb. This is only a 2-year-old child. And the recommendation is to give RIG in the wound. For a 2-year-old child, it was very difficult to instill because
Pankaj,
without anesthesia, without sedation.
First of all,
so how to go about it?
In these cases, if any sedation is needed, or you can restrain the child, and of course, if it is in the pulp of the finger, this thing you cannot administer the whole dose over there because it will lead to compartment syndrome. So,
right.
Possible, you give only that much amount.
Okay, so little bit only can be given, and rest can be given intramuscular.
Dr. Mala?
So, actually, now this fingertips and eye, these are some of the very tricky sites, but ideally it should be given locally. So one should definitely make an attempt to infiltrate as much as can be done without causing this compression syndrome in the locally. There is less point nowadays. I think next guidelines will see the recommendation also that there's no point in giving intramuscular injection. So wherever anatomically feasible, you give it at site. If it is not feasible, like aerosols or like where anatomically it is not possible to give, then you have to give intramuscular. But intramuscular has very less role for the simple reason that the whole immunoglobulin gets diluted in 5 liters of blood and then it gets distributed.
Dr.
So that is
Malla, there are some research that whatever amount locally is needed, only give that much.
yes.
And you can skip rest of the dose also.
Absolutely. That's what I'm saying. That anatomy, whatever is anatomically feasible, one should be done. But like in situation where you have aerosol, you're centrifuging the virus in the lab, in those cases, where will you give? So only in those cases, intramuscular has a role to play. Otherwise, you have absolutely, you're right, that just give locally, and intramuscular is, there's not much role.
Thank you.
Chalo, I think it was a very nice interactive discussion and good insight into the issue by our veteran, Dr. Suresh Gupta ji, past president, Delhi IAP. And thank you, Dr. Mala, for your excellent summarizing of the issue. And I think now no more questions are there and we can call it a day.
So congratulations to Dr. Gupta, and thank you for giving me the opportunity to be here. Thank you so much. What a pleasure it was.
Thank you, Dr. Bhandari, Dr. Mala, and all the participants.
Thank you.
Okay.
Thank you.